I'm very, very pleased to introduce Professor Gail Hayward, a GP and clinical director at the National Institute of Health Research Community Healthcare MedTech and IVD Cooperative. Have I got that right? Sorry, I had to read that out. I couldn't memorise that. She's got a particular penchant for research about the testing regime for UTIs, and that's what she's here to talk about. And given a couple of the conversations from one of our earlier talks, I'm hoping this will be a really fascinating subject. So with lots of questions afterwards. Okay. All right. Over to you. Thank you.
Thanks very much. It would be really helpful just to know who I'm talking to a bit. So I wondered if you could put your hand up if you're working in the community in healthcare. Great. Hi. And secondary care. And people who prescribe antibiotics. Quite a lot. Great. Thank you. So as mentioned, I'm a GP researcher. I'm particularly interested in infectious diseases and diagnostics, and I think the most important place where those two things meet is UTI. So I was given quite a lot of things I was meant to cover in this talk today, but I'm going to talk to you a bit about research that we've been doing looking at UTI diagnosis at the moment, how good it is, some research that we're planning to do and doing to improve UTI diagnosis, some NHS and research policy initiatives that are in this area and hopefully will help move things towards better conclusions sooner. And then I was also asked to talk a bit about the NIHR research environment in general and how you can get involved more. So all of that coming up before lunch. So UTI in primary care is a huge diagnostic challenge, and we face it very often. It's the commonest bacterial infection coming to primary care, and in primary care we prescribe 80% of all the antibiotics in the UK. Symptoms can get better without antibiotics. They can be due to other causes, but if we don't treat or undertreat, we know from trials women have a longer duration of painful symptoms, and we do know that there's also a risk of bloodstream infections and sepsis. Resistant rates are growing for the narrow spectrum antibiotics that we're asked to prescribe, and we're under pressure not to prescribe the broad spectrum antibiotics that might be more effective first line. And this is even more challenging where we're trying to treat children or diagnose UTI in children and in older adults, particularly older adults with higher incidence of asymptomatic carriage of bacteria. So a big challenge, and something which isn't seen as such a big challenge, I think, outside the educated people in this room. So how do we decide who needs antibiotics? So roughly, we use symptoms, we use the appearance of the urine, we use dipsticks, diagnostic algorithms that combine those first three, and culture. But in real life, practice is very variable. This is a survey, somewhat messy graph of a survey of about 200 GPs asking, what do you do? And the answer is they do all kinds of different things in different proportions for different patients. In a study my colleagues did looking across Europe, across 4 European countries, about 68 to 95% of patients had at least a dipstick. The UK, I think it was on the lower end of that. So how about appearance? There have been some studies looking at cloudy urine. My mentor at Oxford says, you could just hold the urine up to the light and you could tell in the kind of the bush medicine approach. There is a bit of evidence that the odds of infection are greater with cloudy urine in two studies recently, but it hasn't really been tested in a large population. Dipsticks, I think you'll all have been familiar with. They're a bit tricky that because their qualitative interpretation can vary, but all of the different technologies that have come along more recently to measure the change in the colour of the strip don't really add to the performance of the dipstick that much. There are multiple variables, and it's not really clear how you combine them best to interpret the dipstick. The research we've done in primary care populations suggests that we would misdiagnose about a quarter of positives and nearly half of negatives using urine culture as a reference standard. That was a study a few years ago and used a particular combination of the nitrites and the leukocytes. And a study I really like, which is now quite old, randomised women who'd had a negative dipstick to get antibiotics or not. And the women who had antibiotics despite a negative dipstick got better faster than the women who didn't have antibiotics. So we know that dipstick isn't really perfect. So one attempt that has been made to try and improve the situation of looking at the urine or looking at looking at dipsticks, is to try and combine symptoms, dipsticks, and appearance all together in a diagnostic algorithm. And this isn't something just the UK does. There are various diagnostic algorithms across the world internationally. This is one of the recent iterations of the UK HSA guidance. This is a kind of retyped sign guidance, the Scottish guideline network, which are quite different and have very different criteria in them. And so a bit of research that we've not yet published, but we've just finished in our team, has been to look at how well these perform. And so what we did was we used a cohort of women who we'd recruited to a trial, and they'd all come to see the GP with a suspected UTI, all over 18. And about over 1,000 of them were recruited into this trial. And while they were recruited into the trial, we got to record their baseline symptoms, and we made sure we recorded all the baseline symptoms that were on these guidelines. And then we also did a urine dipstick on all of them, and we did a lab urine culture on all of them. And the intervention they had was, after that point, it wouldn't have affected the result. We asked them to, this is a little bit fine print, but we asked them to tell us their symptoms on a scale, because you need some way to try to define what symptoms are. And we chose for this study to assume that moderately bad or worse was a genuine symptom, but slight problem or less wasn't, because we had to pick a cutoff. But I'll mention that a bit more in detail later. So this is the UK HSA guideline with the women in our study running through it. And as you can see at the bottom here, the outcomes from the UK HSI guideline give you three options. UTI less likely, where they suggest don't prescribe antibiotics. UTI equally likely, or UTI likely. And in both of these, you can under the guideline prescribe, although in this one you're advised to consider a culture. And so what we found was that in the UTI likely box, 311 women with a positive urine culture were classified here, but also a reasonable number with negative cultures into this box. And a reasonable number of women with positive cultures came into both of the other categories. So not a perfect performance, although it was picking up a lot of the positives. That's a really complicated slide. One other thing I just wanted to mention is when we started looking at this guideline, we realized that this box here didn't exist on the guideline. So people who had severe symptoms, had a urine dipstick, and were positive for blood weren't accounted for at all in the guideline at the moment. There's nothing, we don't know what to do with them. So we kind of guessed what would happen to those and put them in here. And we've just been fortunate enough to be talking to the committee who are making the new guideline, and now they've spotted that and they're going to update it to include this box. So probably the biggest impact of my career has happened right there. So this is just another way of showing those results, showing that if you came into the UTI likely, the number of women with a positive culture was higher, but it was still also higher in the other two arms of the algorithm. This is the sign guidance. This is much more restrictive. You have to have a positive nitrite on your urine dip, which is not often something I see as a GP, to be honest, to be offered antibiotics. And so here, they were very good. This algorithm is very good at picking up positive cultures compared to contaminated or negative. But 289 women with positive cultures would have been advised self-care, and plus more not meeting the criteria in other parts of the guideline. So in the sign guideline, a lot of the women in our trial would not have been given antibiotics first line despite having a positive urine culture. So in summary, in the sign guidance, hardly any women with a negative culture would have received antibiotics, but only 13.7% of those with a positive culture would have received antibiotics. So it could be under-treating. Under the UKHSA guidance, 81% of all women could receive antibiotics, but so would 61% of the women with negative culture. Now, there's a big problem with all of this, which is that urine culture isn't a great proxy for urine infection. So it's possible that either of these guidelines is doing the right thing, because we don't know how good urine culture is. But our conclusion, at least with what we can know, is that if we take symptoms and we take dipstick and combine them, it's probably not going to be accurate enough to predict who would have had a culture in the lab. And it's a helpful thing to know, but it's also not a particularly constructive thing to know without knowing what to do next. So what we've been doing since is working with that team to try and say how we think you could recombine the symptoms of the urine dip to try and get a bit of a better performance of the guidelines. So hopefully that's going to feed into practice. So, urine culture, we've already touched on it a few times. So it's definitely an imperfect reference standard at diagnostic. So its ability to tell us the truth is in doubt, I would say, about infection. It's also not a great tool for a primary care physician. There's a long delay before we get results. It's based on criteria proposed in 1956. And in preparation for this talk, I actually tried to get the paper from the Oxford University Library, which is meant to hold all papers on anything. And it did have it, but it was in a basement storage room off-site. And by the time it got from that storage room to the library, it was today, so I wasn't able to bring it for you. It can't distinguish between infection and asymptomatic carriage, and that we're not sure how much of a problem that is at different age ranges in the different settings. We know that in the nursing home or residential care population, it's a bigger problem. In terms of the actual figures for the rest of the sort of UK or equivalent country populations, we're not sure, but we are going to find out. We're doing a study to look at how prevalent asymptomatic carriage of bacteria is across different populations. So watch the space for that answer. Culture can miss potential infecting bacteria, particularly now that we have access to genetic sequencing. There is definitely a difference between what you get from a genetic sequencing approach and a culture approach. And I'll touch on that a bit more later. And also, there's a lot of hypothesizing about what happens to transport time. Some people think it's going to be overgrowth of an important bacteria. Other people think that the infecting bacteria are interested in are going to die. I think in the studies that we've done, when we've looked at this as a variable, we haven't found much difference in samples that have taken 1, 2, or 3 days to get to the lab, but they haven't been large enough sample sizes to know, really. I discovered recently that I've been religiously putting my urine samples in the fridge in our GP surgery reception before I went away for the night, because I do an afternoon surgery. And then I put my hand in the fridge and said, "It's not very cold, this fridge. Did you want to check if it was cold?" And they're like, "Oh, no, it's not a fridge anymore. It's just a box that you can put your samples in. It doesn't work as a fridge." I think 10 years I've been doing that, assuming that I was refrigerating my samples. So the other big problem with urine cultures is contamination. I suspect everyone in this room has had multiple experiences of talking to a patient about the fact that they've sent this test off. It was meant to tell them what bacteria are there, but actually it's come back with a totally useless result. So in approximately 1 in 3 women, we send this test off, we say it's going to tell you whether you've got an infection, and what it tells us is totally useless. It doesn't give us any guidance as to whether there's an infection there or not. Why is that a problem? Well, patients don't get a diagnosis. Treatment for resistant infection is delayed because we have to repeat the culture, and often when we repeat it, it's contaminated again, or that's at least the clinical. I can't prove that with data, but that's what I get clinically. We're wasting a lot of money repeating these cultures. We're promoting empirical antibiotic treatment because if the culture is likely to be useless, why would I wait? And in Oxfordshire, we found 26% of all cultures sent from primary care were contaminated, and that's on a population where 36% of the population had had a urine culture test in 10 years, so it's big numbers we're talking about here. So we, a couple of years ago, maybe last year, published a trial that we'd done looking at urine collection devices as a possible solution to this, called the Conduct trial. These are 2 different types of collection devices which claim to be able to take the midstream of the sample. In theory, the first bit of the sample that you pass washes off all the bugs, and then the middle bit of the urine stream won't have any of those contaminating bugs in it anymore. And there's a question as to how true that is, but these devices were being marketed and used in the NHS in the UK to try and reduce contamination rates. So we said, well, for one of these devices, the only available evidence, published evidence, was an abstract in a conference based on a male UTI population who could be arguably having different problems with collection to women. So we thought it was useful to try and do a larger study to find out. So what we did was a randomized trial where we randomized women to either just use a pot, and we gave them instructions on how to use the pot, or to use one of these 2 devices. The groups were similar at their baseline, in the baseline number of samples, in the baseline characteristics, and about similar in the number of women. And our primary outcome was the proportion of samples in each group that were reported as mixed growth. So as you can see, there wasn't all that much difference between the proportion reported as mixed, depending on whether they used the collection device or they didn't. And further to that, we had more device failures as in the patient wasn't able to, despite being able to do a wee, wasn't able to do the wee in a way that, you told me not to hit the thing, didn't you? Wasn't able to do a wee in a way that collected a successful sample for us. And that was almost 25% of the recruited participants for one of those devices, which would add cost to this as an intervention if we were going to try it going forward. So then we did a second device, only including the women who successfully used the device they were allocated. And similarly, there were no real differences in performance across the three. So urine collection devices, probably not the solution for contamination. What might be the solution is looking more into the genetic or genomic testing to try and work out which of these women with mixed growth samples actually have an infection and which actually have a really polymicrobial mix of all kinds of bugs. And we've started doing some work on that, which we presented at a conference, but I really need to write it up and try and pursue that a bit further, because I think there's some indication that at least for some of those women, more advanced techniques could start to kind of divide out what's happening. So what's the patient experience of urine testing? So Margaret, who is here with us, done some really great work interviewing participants in some of our trials and asking them what had happened when they'd gone to the GP surgery and what their experience of this kind of being asked to take samples and what happened next. And one thing we asked about was contamination, and most of the women interviewed, despite being recruited to a trial about urine collection devices, weren't really aware of the issue of contamination. One of them just said, I didn't know. And although one woman thought that the contamination could come from the body, mainly it was thought to come from the specimen container. So the second quote there is, I really cleaned my mug well before I did the wee in it, because it would avoid the contamination. Even yesterday I got a jam jar full of wee in my GP surgery, which is a sharps disposal nightmare. What's the understanding of midstream sampling? Well, some women said it's really pretty hard to catch a midstream sample. If you're doing tiny amounts of urine and then you're trying to catch it, you can't really get the midstream because it's gone. There's no midstream. There's just the first bit. And then something we hadn't really considered was the impact of something like a prolapse, where you're trying to stop weeing and then start weeing again, but you just can't because you've got a prolapse and the muscles aren't there to do that anymore. So it's challenging in multiple ways. And how might urine collection be improved? Well, quite a few different suggestions for better information, this being one of them, that we should be making a habit of repeating this when we see patients. I'm guilty of this. I don't, every time I hand a sample pot over, spend an extra minute really clearly explaining what to do. And maybe that is the best type of information, because you could interrogate that information. But also, as they're right, there's a lot of posters in waiting rooms in all healthcare settings, and if one of them was a really clear picture of how to do this, maybe that would be helpful for women and something that wouldn't be that hard to do. In terms of experiences of receiving results, well, we found that there was real variability in the amount of information, the timing of the information, the quality of information women reported receiving from their tests. And so I've given you kind of two contrasting quotes to read here on dipsticks. I'll give you a few seconds to read those. And similarly with urine culture, there were also contrasting experiences. Some people found that they were sort of being involved in the process and they felt that their journey had been improved by this test, and other people just didn't even really seem to get the result. So in addition to information needs about how to collect a test, probably there is an information need for how to understand the test, how to understand what testing you're going through. And there has been an information booklet, hasn't there, Margaret? And I can't remember exactly what it covers, but there's been an information booklet produced, which would be something which would be interesting to look and see how effective it is since we did this research. Okay, so it's been a bit gloomy so far in that diagnostic algorithms are not perfect. We would never expect them to be, but they're not perfect. Urine culture has a lot of there are a lot of challenges with interpreting urine cultures, and it's a technology which is our kind of main existing reference standard, and patients' information needs aren't fully met. But I think there is hope, and I think there are various different technological innovations coming along which offer hope for improving diagnostics. One of those is biomarkers. So if we don't look at the bacteria in the urine, but instead we look at the bladder's response to infection, we can potentially test the urine for biomarkers which tell us the bladder is fighting an infection right now. And there's been quite a lot of work done on this, and we've recently published a review where we looked at every single paper ever. It made the research assistant working with me turn to the prison service, and now he's in the civil service and he's left. It was such an ordeal. Not just for that reason, but he went through thousands of studies and found 37 had been performed looking at biomarkers on 66 different biomarkers that had been evaluated. But unfortunately, most of the evidence was quite low quality in that they got people with definite known UTI with a culture right then and people who were definitely healthy, and they compared the two things. And that goes so far, but then if you want to use this in a clinic, you need people who might or might not have a UTI, not people who you're very confident either way. And so the performance in that population that we need to use as clinicians isn't really established. A couple called IL-6 and IL-8 were the most studied, but there was some plausible evidence to suggest that a range of others, which I couldn't even tell you their full names right now, could be worth further research. And hopefully, us having published that will help companies and other research groups consider looking at these further. The next potential innovation is novel point-of-care tests. I'm not sure whether you've come across any of these, but they've been in higher profile recently because of the Longitude Prize, which is a sort of multi-million-pound prize for technology which can help in antimicrobial stewardship to try and tell the difference between infections that are caused by bacteria and those that are not. And quite a few of those tests are focusing on UTI and trying to improve prescribing of antibiotics for UTI. All of these funny-looking pictures on this side are of the way a technology by Sysmex Astrago works, where these little red things are the bacteria. And the idea is that the bacteria in the urine go down those little tubes, and then they start to multiply, and then in one set of tubes they're left alone, and the other set an antibiotic is inserted, and the amount of multiplication and growth is compared, so they can look in real time at whether there are bacteria there and whether antibiotics kill them, and it takes about 40 minutes. And another technology here by Lucerne Diagnostics is using a kind of molecular approach to pick up individual bacteria and say there is E. coli in this urine, there is Klebsiella in this urine, and do that again in a sort of 20 to 30 minute window. So what's really needed next, we think, is a way to evaluate whether these tests work to diagnose UTIs in primary care, in a kind of busy primary care population rather than in a lab. And that's a study called the Toucan study that we're about to start. We're kind of working through the paperwork to get going, where we're going to take some tests like these into a platform and compare how they perform to a standard NHS culture, but also advanced culture, and also each other, because we're aware that culture has its limitations, and try to give some of those answers about how these tests could perform if we took them into the NHS to speed up their implementation in NHS settings as far as possible. The other advance is genetic sequencing, and I'm not an expert on this, I'm learning about it, but I'm not sure I'm going to be great at answering all the questions. But sequencing of urine samples is definitely happening. Direct from sample sequencing is now possible, so you don't need to grow a bug and then sequence that. You can do metagenomics on the whole urine. It can give you this sense of all the bacteria present in the bladder. That includes potential microbiome bacteria and potential pathogens infecting bacteria. And it might well be able to identify infections that are not captured by standard culture. And I know that SBL is here, and we're starting a collaboration with these guys who are doing amazing things, trying to look at the whole microbiome and how that changes in infection, and working with us on some work on recurrent UTI. I guess the caution for now is that I think we need more research to understand first how to collect and process these samples for sequencing, particularly if we're not collecting them right next to the lab where it's being done and they need to be shipped and processed. Do we need to spin them immediately? What reagents should be there? And we really need to understand how to interpret the sequencing results and how they relate to the symptoms in patients, how they relate to the need for antibiotics, because it's such a rich and complex data set you get out of this sequencing. It's not as easy as, oh, there's an E. coli, you should treat it anymore. And so that's going to take a little bit of time to really be confident about, for the masses at least. It's also quite expensive currently. It's getting cheaper and cheaper and smaller with the years. But I think unlikely to replace culture or just simply empirical antibiotics for all patients. But what we really need to understand is which is the population who this would be beneficial and cost effective soon or now. And there still are some issues with sample contamination. We're still going to be washing bugs off the perineum, and how we tell which bugs are in the bladder and which bugs aren't is still an issue, I think. So final bit of research, just a plug in case anyone might want to do this one with us. I've talked all about diagnostics, but we're also interested in UTI treatment in our team. And this is a trial that, again, is just going through the setting up phase, trying to look at what the best duration of treatment would be for a UTI. And I've put these pictures up because at the moment, the way that we decide how many doses of antibiotic we need is either on how many turns of the earth happen or how many days a week were established by a Christian calendar in early Christianity, which doesn't seem like a kind of very modern way to decide how many antibiotic doses you need. So this trial is taking this sort of novel approach of comparing multiple different durations of antibiotic, of the same antibiotic for women with UTI and women with kidney infection. So there's an in-hospital arm for a neurologist in the audience and a community arm to try and answer that question and answer the question, what is the impact of that on your bacterial resistance in your gut at the same time. Okay, I'm wondering whether I should pause for questions then, and how long have I got? Because the next bit is about NHS and policy.
You've only got sort of 15 minutes for questions then.
Okay, I'll just keep going. This last bit is fairly quick. So just touching briefly on recent NHS and NICE developments, there's a new process in NICE trying to look at the early value of potential diagnostic and other technology, including digital technology. And one of these, the focus of one of these is UTI, rapid tests for UTI. So that's an ongoing process which I'm involved in, as is Chris Harding. And I suspect there will be some publications related to this coming in the next few months. In terms of the NHS, they're currently working at the next AMR National Action Plan, and they're looking for input into what that should be and how we should improve our response to AMR, and they're looking for broad input. So if you're interested in inputting into that, you can do that online, I think. They also have, within NHS England, they have an AMR Diagnostics Programme Board, which aims to try and use diagnostics to accelerate better antimicrobial stewardship. And they have a particular sepsis, RTI and UTI focus. And they're involved in horizon scanning for new technologies. They've been running some stakeholder workshops, which I think Bladder Health UK helped to support, and mapping the pathways for diagnosis in UTI. So I'm optimistic, again, that there's this policy focus is building. And finally, in terms of the research landscape more broadly, the NIHR, the Medical Research Council, and Innovate UK are all supporting diagnostics through their various streams, and there's opportunities to get involved if you want to get involved in research, not just by doing the research, but also inputting into priorities for the research. So you can contact the NHR and say, I think this is a really important question that needs to be answered, and they would take that into account when they advertise their next research projects they want to do. So finally, there was a long word at the beginning, which is the organisation I lead in Oxford. It's called the NHR Community Healthcare MIC. MIC means Medtech and IVD Cooperative, which means technology for healthcare and in vitro diagnostics, which are blood, urine, things that come out of people. And we particularly focus on generating evidence for commercially available tests, so tests that have already been CE-marked, and helping companies develop tests towards being CE-marked. Which are really fit for purpose in the community, so will actually make a difference for people working in community settings. We help companies design, we help work out the economic modelling, we help do accuracy studies and randomised trials, but we're really dependent on input from people like you into what are the priorities, what are the important things, what could we be guiding companies to do, which we don't know is a priority because we obviously can't be clinicians in all the areas or can't see the whole patient journey. So how could you get involved? Well, contributing to NICE stakeholder engagement is always an option. They advertise those opportunities on the websites. contributing ideas to NIHR commission calls. As I said, if you think something's a real research priority, there are committees that aim to try and prioritise research ideas that you can feed these into. Supporting research delivery where you work via CRNs, I'm sure lots of you do that, and if you wanted to, you could do that for our 2 new studies which are coming out. Support your patients to engage with research. I think Bladder Health do a great job of this. They've been so supportive in sourcing appropriate patients to join all of the studies that I've mentioned, and give us their kind of ideas and their guidance. And if you have ideas for better diagnostic technology, then do that with us. And after lunch, so in the second half of the lunch break, myself and Margaret and Phil and Heidi will be in that box there, which won't be a box anymore. the partition will be back. If you'd like to come and talk to us about any thoughts you have or talk about this any further, then please do. Okay, I think I'm done.
Thank you very much. Huge amount to go through. And hopefully some time for some interesting questions as well. So, who's first? Come on. I know there's lunch, but we're not getting out of here until we've had a few questions.
Me, I'm first. Thank you very much. That was a really interesting talk. Something that was quite interesting to me, that I was mulling over, is using biomarkers in urine to work out urinary tract infections. And the reason is that if we're looking for inflammation as well as infection, you'll get IL-6 and IL-8 in both scenarios. So I was just wondering how you'd use that in order to get more info.
Well, I guess there's a kind of more basic decision about what inflammation is, and is inflammation a response to an infection, or is inflammation a process where your body's attacking itself, basically?
Yeah.
And those are the 2 main causes.
And how would you actually measure the level of infection there as well?
Some of the technology that we've been involved in is trying to do both things at the same time, and it gets a bit confusing, but the idea is there bacteria there, and is there evidence of inflammation or a response to an infection?
Yeah.
And if yes to both, then treat. If yes to one, monitor. If yes to neither, don't. I think that's the kind of idea. But there aren't any technologies that have got close enough to market for us to test that out yet. There are biomarker ones and there are other bacteria there ones, but the 2 things together, we keep suggesting that to developers, but it isn't there yet.
Yeah. And is there any way of quantifying if you do it genetically as well?
Genetically?
You know, you were talking about genetic sequencing of the various bacteria.
Yes, there is. The standard approach is to take a bacteria which could not possibly be in a human and put that into the sample. I think SBL with their store could tell you what they're doing, which might be a bit different, but that's one way to do it. Yeah.
Thank you.
Hi, Gail. Based on your research and your experience then, how do you treat a UTI in your GP practice? How do you summarise it all?
Well, I guess it's maybe less confident in the algorithms, so I tend to use more... I rely more, I think, on history and their previous history of UTIs. And I do use dipsticks because I think there is some additional benefit. But I also recognise that I'm slightly flying blind, so what I try to do is not prescribe antibiotics unless I'm fairly confident, and when I do prescribe, I prescribe narrow spectrum, like I'm told to in guidelines. But I think we sort of need to... I think GPs can be... Well, we can all be forgiven at the moment because there isn't a great new approach we could use to make this better, but I think they are coming. So I think 5 years from now, this could be a different talk, hopefully. Yeah.
Okay, and also if talking about patient technique at taking good samples, and I'm a pelvic floor physio in private practice and also NHS, how often patients will say, I'm really struggling to get an appointment. I'm sure you've heard that as well. How accessible do you think regionally at dropping samples off are? And if sometimes in my NHS clinic, for example, I might give a urine sample and say, well, you can try dropping off. Some GPs are receptive, some aren't. Is that something to look into? So it's easier access? Is that helpful? Is it not? Is that bad advice for me to give? I don't know.
Well, I think the problem is when you try to say GPs, you've got to remember that this is like thousands of independent private practices, all of which do slightly different things. So it's hard to kind of speak for GPs. In my surgery, we still accept samples and dip them and send them to the duty doctor. But that has tailed off since the pandemic because so much remote consulting meant that patients weren't encouraged to do that. So now there's having to be kind of a shift back. pushing a shift back towards testing for UTI will increase workload, and that is part of the equation of what do the next guidelines look like, I guess.
Yeah, I guess that's the journey that could be looked at, isn't it? And that the nipping it in the bud, isn't it? And early diagnostic and treatment.
Yeah.
Lovely. Just wanted to get your opinion on 3-day antibiotics. What are your thoughts on that?
As in 3 days of nitro?
Yeah.
Yeah. Well, many women respond well to that. I think the honest answer is that we don't know from any research that I'm aware of what the implication of a shorter or a longer course is. There's always been told you've got to complete the course, you've got to take adequate antibiotics to really kill the infection. But we know now, there's lots of studies coming out that taking lots of antibiotics does have implications on what happens next in your bladder. There's a team in Oxford that their theory is if you take a lot of antibiotics, you basically wipe out all of the sensitive antibiotics in your gut, and then the resistant ones come crawling back in right after you finished your course. It's a theory, and it's only one data set, but I think we just don't know, and that's why studies like this duration study are so important, to see what the impact is and what the positives and negatives are. Yeah.
Thank you.
Hi, Gail. Listening to your presentation, thank you very much. Everything is upside down now in my head. Whatever we have learned in our medical school and after that years of practice, we know that certain things, algorithm, this, that. But looking at your presentation, there were like self-caring, 289 patients culture positive, and they were told to do self-care. That is a huge number. And we really need something, biomarker or whatever it is. In our practice, when I was doing my training, we were told that the best way to do urine sample is suprapubic puncture and take the urine from your bladder. That's not going to happen because, it's difficult. So we know that this is a huge problem. And contamination-wise, and what about urine dip? It's not at all predictive. What about cultures? It's not. So what we do, where we are, nothing is happening, isn't it? After, 21st century, let's say 2023, we are still in such a huge mess and problem with recurrent UTI. And no wonder we see day in, day out those women coming to us and saying, oh, this, that. Of course, we will give imperative antibiotics. I don't blame GPs or us. It's a medical, legal implications there. If you don't treat them, you're damned. If you treat them, you're damned. So what do we do? That's why antibiotic stewardship and all those things are happening these days, and we talk about it every day. But we don't have nothing to say, yes, this is what is the correct thing, and we'll do this. And like you just answered the question, 3 days, 5 days, 7 days, 14 days, what do we do there? We don't have any answer yet.
But you will do in about 3 years.
I'm not sure.
I guess, and the other, just to make you even more confused, I guess the other question is, just because we can find evidence of an infection in the bladder, do we need to treat it with antibiotics at all? We know that women can recover from UTI without antibiotics. We know it's more painful and it takes longer. Is there a way that we could try and find the women where it wouldn't be that much more painful, it wouldn't take that much more longer, and separate those from the women who definitely need antibiotics? Because in the end, for stewardship purposes, the less antibiotics we can prescribe at all, I think, is the aim. But we don't want to do that in a way which makes anyone have any additional distress or suffering or symptoms. So that, taking it right back to basics, that's really the question, but that's a very different question to answer.
Can't keep up that side. You've got one question.
Hi, I'm a urogynecologist in Leeds, and a big problem for us in secondary care is, in particular with the backlog of COVID, and surgical spots are at a premium, and we do day of admission urine test, and they have a positive urine. We tend to use, if they're nitrite positive, then we cancel the procedure. We send off an MSU, and invariably they come back negative. you hinted that you've done some sort of work combining the Scottish algorithm and the other one. What would you say would be a viable dipstick test to cancel a surgical procedure?
That's a really that's a really tricky. I don't think the decision that you've made clinically is unsensible, because it is very good at it's good at ruling out UTI and nitrate. Right, there are a few in general, and in this study, nitrate positive UTI is quite likely to be UTI, or nitrate positive women with symptoms are quite likely to be UTI and not very likely to not be UTI, more importantly. It's very tricky. I guess it's about balancing the risk, isn't it? What's the risk to proceeding with the surgery, and how many more antibiotics are you going to give them during the surgery because you're worried about them? I don't have an answer for you.
Can I just comment on my own here? So I do lots of flexible cystoscopy, and we do first urine test before we do the flexible cystoscopy and say, okay, if there is infection, we should not do. That's the guidelines. Nowadays, it's so unreliable. And sometimes people are waiting for months and months, and they come in nitrate positive and leukocyte positive. So what I do now, I've started, because when we send the urine sample, they come back negative most of the time. I said, okay, symptom-wise, if he or she is symptomatic, then I will not send them home with antibiotics and culture send. If they are asymptomatic, then I carry on. And of course, catheterized patients, stenting patients, I don't care about what I see on urine deep at all, because we expect that there will be some leukocytes and bloods and all those things. So it's a clinical, decision. If you start canceling everything, that will be 50% of cancellation, and it doesn't work. That's why just symptomatic patients, we send them back and cancel and rebook. Otherwise,
because
carry on.
A lot of people will just carry bacteria asymptomatically anyway. So, yeah.
One last question. Back there, well done.
Thank you, Gail. I'm one of the Urogyne consultants. It seems we have a very long way to go in diagnostics. So have you got any experience, or have you heard of role of infrared spectrometry in diagnostics in UTIs?
I'm going to give that one to Phil. Have we? Phil talks to every company in the MIC about this.
It picks up biological or organic material in anything, and it is spot on, like it is on the spot rather than sending urine for culture. I was just wondering if there is any role of it to be developed if industry people are here in future.
I mean, people have started looking at Raman spectroscopy for this.
Mm-hmm.
I mean, there's a number of companies that are doing this at the moment, but they're sort of relatively early stage.
Okay, thank you.
Right, thank you very much. I sense, especially from your comments there, that we've gone from 1955, where everything was stable and everybody believed that was what it was, up to about 2 weeks ago, and now nobody quite knows what's what. That's the layperson's view, obviously. Gail has a workshop in the second half of lunch over there as well, if you want to discuss this in any more detail, and he's around until a bit
3. Yeah.
But in the meantime, please put your hands together to show appreciation.
Thank you.